Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Jamie Lesnock from UPMC Magee Women's Hospital and Dr. Sarah Buberhan from Mass General Brigham Cancer Institute, authors on Systemic Treatment of Ovarian Cancer Recurrence, ASCO Living Guideline, version 2026.1.0. Thank you for being here today, Dr. Lesnock and Dr. Buberhan.
Thank you.
Thanks for having us, Brittany.
And then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Lesnock and Dr. Buberhan, who have joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into the content that we're here today to talk about, Dr. Lesnock, could you first start off by providing a general overview of the scope and purpose of this guideline on systemic treatment of ovarian cancer recurrence?
Thank you, Brittany. Yes, I am happy to say that this is the first guideline for patients with ovarian cancer who have a recurrence to address essentially treatment options for their recurrence. So the purpose is to provide evidence-based guidance for providers as to both systemic therapy treatment as well as surgical options for patients who recur. The scope includes all patients with recurrent ovarian cancer, although we have limited it to a specific group of histologies, specifically high-grade serous and high-grade endometrioid cancers.
Excellent. Thank you for that background of the context of this guideline. So then, Dr. Buberhan, I'd like to next review the key recommendations of this guideline by clinical question. So starting with the first clinical question, what does the expert panel recommend for systemic therapy for patients with recurrent platinum-sensitive ovarian cancer?
So our panel actually defined platinum-sensitive recurrent ovarian cancer as those patients having a recurrence greater than or equal to 6 months from the last dose of their platinum-based treatment in the upfront setting. And then this recommendation would apply to that subset of patients. The current recommendation coming forward from the guideline is that we focus on platinum-based combination treatment as a systemic backbone with a selective incorporation of bevacizumab. The panel acknowledged that bevacizumab has been shown to prolong progression-free survival. However, it's at the expense of additional treatment-related toxicities. So clinicians are encouraged to consider that on a case-by-case basis. And then we also note that there's 3 well-studied platinum doublets, carboplatin and paclitaxel, carboplatin and gemcitabine, carboplatin, liposomal doxorubicin. The panel did not have any specific tiering of the recommendations for which doublet was preferred, but any of them could be considered, again, considering patient factors on a case-by-case basis.
Excellent. Thank you for reviewing those several options for patients with platinum-sensitive epithelial ovarian cancer. So then, Dr. Lesnock, for those patients whose disease has responded to treatment for recurrent ovarian cancer, what is recommended for maintenance therapy?
Yes, thank you. So to build on Dr. Buberhan's comments, we essentially were able to look at studies that included the addition of bevacizumab to the platinum-based doublet chemotherapies that she spoke about, and basically showed that the addition of bevacizumab to combination chemotherapy in patients specifically with platinum-sensitive ovarian cancer is essentially can be offered by clinicians with really a strong level of recommendation by the expert panel. This was based on a group of studies that had overall moderate evidence quality, but showed an improvement in progression-free survival, which essentially shows that we can extend lives in a meaningful way. And although there was not an improvement in overall survival, the ability to balance extending time until the next therapy has benefits to patients as long as the patients are aware of the toxicities that may come with that. So ultimately, the recommendation is that clinicians may offer this combination platinum-based therapy with bevacizumab and then maintenance bevacizumab to follow. There is some commentary in the guideline as well with regards to PARP inhibitor maintenance therapy, but this really has been deferred to the ASCO PARP inhibitor therapy guideline. The update is soon to be published.
We'll look forward to that PARP inhibitor update along with this guideline to inform many different options for patients with ovarian cancer. So then the next question addresses surgery, with which Dr. Lesnock mentioned earlier is included in the scope of this guideline as well. So, Dr. Buberon, how does the expert panel address the role of surgery in patients with recurrent platinum-sensitive ovarian cancer?
Right. Thanks, Brittany. This is another really good question. So the panel had reviewed multiple randomized controlled trials looking at surgery as an intervention in the platinum-sensitive recurrent disease setting. The challenge really is that the results from these studies are mixed. So ultimately, the consensus statement the panel put forward was that secondary cytoreductive surgery may improve outcomes in carefully selected patients, emphasizing those in whom gross total resection is considered likely feasible. And then there is that acknowledgement that the results are mixed, which we did include in the consensus statement. There was a lot of discussion in this area. A key point that was emphasized is that there may be many patient-specific factors like platinum-free interval, the size and the extent of disease, which may have an impact on outcomes in the role of the secondary surgical cytoreduction, though this conclusion is difficult to definitively derive from the available trial data. So it's put forward that patients may be considered on a case-by-case basis for a secondary surgical cytoreduction in the platinum-sensitive setting. Another point that came up was the role for HIPEC at the time of disease recurrence or following a secondary surgical cytoreduction. Again, multiple trials were reviewed, and the data is conflicting on the potential benefits of HIPEC. The consensus statement is that HIPEC should not be recommended outside of experienced clinical centers or in a clinical trial setting, at least at this point in time. I'll also let Dr. Lesnock weigh in as well. I'm a medical oncologist. She's a GYN oncologist. So she has any other insights from her surgical expertise.
Thank you, Dr. Buberon. I would add that it was difficult making this recommendation. Hence, the ultimate recommendation is that we don't have a recommendation for or against, because I think the balance of identifying the patient that would benefit the most, i.e., the person who will have all of their disease removed with surgery, can sometimes be more challenging than we hope that it would be. And as Dr. Buberon said, these patients, for sure, if they can have all of their disease resected, will benefit. And so surgery is a benefit in all of the studies, and in some studies, even in overall survival. But that being said, as she noted, the detriment, the opposite effect in which surgery is undertaken and we cannot remove all the disease, may harm a patient. And that's obviously not our goal. And so I think that the key point in my mind is just the involvement of essentially the surgeon, the gynecologic oncologist who is involved in that patient's care, to help with those decisions as a multidisciplinary approach to these patients who might be treated in the community with excellent doctors like Dr. Buberon, who is a medical oncologist, but just the involvement of the surgeon in that decision-making, I think, is key.
Understood. It sounds like it's an individualized, shared decision-making approach between the surgeon, the multidisciplinary team, and the patient to actually choose whether to perform surgery given the mixed evidence in this setting. So then the next question that the expert panel addressed, Dr. Lesnock, for patients with recurrent platinum-resistant or platinum-refractory ovarian cancer, what is recommended for systemic therapy?
Yes, thank you for that question. And just to address the definition of platinum-resistant and platinum-refractory ovarian cancer is one that essentially has been passed down in the sense that we have defined patients who have recurred within 6 months of therapy as having platinum-resistant disease, and those patients that recur during their platinum-based therapy or less than 3 months of therapy as platinum-refractory. But we have in the paper tried to be very cognizant of the fluctuation of those definitions, and essentially, especially in many of these trials, platinum-refractory recurrences may have been excluded, but the lack of inclusion of those patients does not necessarily exclude them from the exposure to some of these agents. So it's a little bit of a sometimes challenging discussion, and we do talk about that in the paper. But nonetheless, we try to ultimately make recommendations for the inclusion of both of these populations. And we know that these patients, despite a poor prognosis, have multiple options that we identified as having an improvement in progression-free survival. And just to highlight, these are mostly single agents, such as pegylated liposomal doxorubicin, paclitaxel, gemcitabine, and then noting that the addition of bevacizumab, similar to kind of our platinum-sensitive cohort, the addition of bevacizumab actually adds benefit beyond single agent therapy. And probably our strongest data right now with mirvetuximab use in patients who have high expression of folate receptor activity and defined as essentially greater than 75% of cells with 2+ or 3+ staining. So aside from the nuances of the staining criteria and assuming that patients have had this testing, that is probably our strongest recommendation, with then the other agents to follow that. The second thing I would just say is that it was very hard to talk about a sequence for these agents, i.e., do you pick this one first? And sometimes the way we list them may suggest that one is, quote, better than the other, unquote, but not really with a comparative study to do that. But just to recognize that molecular-based testing, first and foremost, should drive targeted therapies, and then the decision about the other therapies is likely to be dependent on patient performance status as much as it is patient preference and what else they have received.
The only thing I would add is that as we were finalizing the guideline, we did get the update from the final manuscript of the Rosella study, which we did include in the guideline. So we did include the combination of nab-paclitaxel and relacorilant as an option for clinicians. But I think you made a great point, Dr. Lesnak. There's no data that really informs the optimal sequencing, and we are having an increasing number of options for our patients, which is a great thing, but definitely an area of unmet clinical knowledge and unmet clinical need.
Absolutely. And thank you for highlighting where there's a difference in evidence for these recommendations and where the recommendations are more based off individual patient characteristics. I think that's really helpful for listeners. So then earlier, we discussed the role of surgery for platinum-sensitive ovarian cancer. So Dr. Buberon, for patients with recurrent platinum-resistant or platinum-refractory ovarian cancer, what does the expert panel state regarding the role of surgery in this population?
Yeah, so there is very little clinical data in this space. So ultimately, we came down and said that there is insufficient evidence to determine the role for surgery in patients who have platinum-resistant recurrent ovarian cancer. Of course, things may change with time, and there likely are patient-specific factors, but right now, not enough clinical data to make a recommendation. I similarly will turn to Dr. Lesnak to see what additional comments she might have.
Yes, this is a challenging patient population to think about surgery. And I think in the real world, rarely are patients with platinum-resistant ovarian cancer going to have surgery outside of palliative surgeries for bowel resections. But there may be a unique population, rare but small population, that has sites of recurrence that may benefit from a resection and in a way that is of low risk to the patient moving forward, given the lack of clear survival benefit.
Understood. I think it's helpful for these guidelines to both outline where there is evidence and where there isn't evidence so that clinicians and patients can make appropriate decisions. So then the final clinical question that the expert panel addressed, Dr. Lesnak, what is recommended for monitoring and surveillance after completion of therapy for recurrent ovarian cancer?
Yes, thank you for that. Monitoring and surveillance is really very interesting in terms of studying this in prospective trials. So really what we found was that surveillance methods have not shown to have clearly a benefit in terms of survival in the way that we think about that. However, we recognize that the surveillance, it's not so much about what is the actual surveillance itself, but how it is obtained. And so there is some data with regards to whether or not biochemical surveillance with serial CA-125 actually improves outcomes, and data to suggest that it does not. However, this evidence is really of limited quantity to preclude us from offering it to the patients. And so I think in general, our findings suggest that we can offer monitoring to patients in a way that matches their goals and ultimately includes a combination of history, physical, laboratory work, imaging, and essentially mostly by case basis, as the combination of one or the other may not apply to each patient.
Absolutely. Well, thank you both for reviewing the recommendations for each clinical question that we just went through. So then I'd like to ask next, Dr. Buberon, in your view, what is the importance of this guideline and what should clinicians know as they implement these recommendations?
I will say, I think one of the strengths of this guideline is that we really tried to use high-quality clinical data to guide the recommendations. Obviously, this is intended to be a guide for clinicians and not a mandate, but I do think another strength of this is that we've really tried to break down the course of recurrent ovarian cancer and to address questions in a step-by-step fashion based at the time of first recurrence, assessment of platinum sensitivity, the role for maintenance, and then the role for treatments in the platinum-resistant disease setting. So we are hoping that that will be helpful to clinicians. I did want to make a comment and to emphasize to our listeners that because we were quite rigorous in the selection of trials that were evaluated in this study, many interesting phase 1b and phase 2 trials were excluded, either because the sample size was too small or the enrollment criteria had too heterogeneous of a population to meet our standards to be considered in this guideline. So I do encourage our readers to take that into consideration. And I'll also turn to Dr. Lesnak, because I feel like this will be a good one. I want to hear her thoughts.
Yeah, I agree completely. This was a challenge to derive a guideline that was held by the rigors of an ASCO guideline. And that's both a compliment as well as just a recognition. There are obviously other guidelines in use in clinical practice, some of which seem much more extensive in terms of options, but we very much tried to abide by the methodology of ASCO in the identification of studies, which, as Dr. Buran said, resulted in exclusion of studies that maybe clinically we like and or might follow. And so just to recognize that this is not meant to be an end all be all, but just a starting point for discussion with patients for the next treatment options.
Definitely. I think putting into context the inclusion criteria of the studies and noting that this is an evidence-based guideline really puts it in context. But I'll also note that as this is a living guideline, we'll look forward to future data being included at a much more rapid pace than is typical for ASCO guidelines to continue to build on that evidence base and expand the recommendations as well. So then, Dr. Lesnak, beyond the impact for clinicians, how will these guideline recommendations affect patients with recurrent ovarian cancer?
Wonderful question. And I will note that we did have a patient advocate as part of our guideline methodology. So that was fantastic. And I think really what I see these guidelines do for patients is allow them to be proactively part of their care in terms of taking to their provider questions about why one treatment, why not another treatment. And again, just a foundation for discussion for steps of action. I think it also is, I really am happy about the inclusion of our recommendations for palliative care and for survivorship issues and for toxicity management around systemic therapies that we have included briefly, albeit in the guideline, but have at least acknowledged that these are a key part of management of patients with recurrent ovarian cancer.
Absolutely. Those are definitely some key points there. So then to wrap us up, Dr. Bubaran, this guideline, as I mentioned, is the first edition of a living guideline on this topic. And we've also covered a couple areas of this guideline where there's insufficient evidence. So what evidence is on the horizon for future updates to this living guideline?
Yes, thanks so much, Brittany. And yes, we are very excited that this will be a living guideline. I will say it was a painful moment. We had finalized the guideline and the Keynote B96 manuscript came out right after that. And we figured everyone would wonder where that was. So we're really excited to be formally reviewing that in the coming months here. There's many interesting antibody drug conjugates moving into phase 3 trials. One in particular, the RENA-S phase 3 open label randomized study, this novel folate receptor alpha targeted ADC versus physician's choice chemotherapy for the treatment of platinum-resistant recurrent ovarian cancer is certainly one that I'll be watching very closely. What about you, Dr. Lesnak?
I equally felt the same whenever even the publication of the updated overall survival for the addition of atezolizumab to bevacizumab and platinum-sensitive recurrent ovarian cancer happened maybe a month after we had acceptance. And even as Dr. Bubaran mentioned earlier, the nab-paclitaxel and relacorilant data having, again, just more solidification. At some point, we had to end the guideline as it is with the exciting opportunity to update on a regular basis.
Absolutely. We'll look forward to the panel's review of this emerging evidence and incorporation of this data into the recommendations of this guideline moving forward. So I want to thank you so much for your work to develop this first guideline of ovarian cancer recurrence. And thank you for your time today, Dr. Lesnak and Dr. Bubaran.
Thank you, Brittany. And I also just want to thank the entire panel and the ASCO staff who were beyond instrumental in obviously making this happen. And Dr. Buberon, who's fantastic and a great addition. So we'll hopefully be helping us co-chair the next edition.
Thanks very much, Dr. Lesnak. I've learned a tremendous amount being part of this committee. I emphasize it's a very humbling process. It takes a huge amount of work and a remarkable number of people to make these guidelines come together. So really excited to have the chance to collaborate and really appreciate the chance to comment here today.
Definitely. And a big thank you to the entire guideline panel and their continued work on this guideline as well. And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.ascopubs.org/guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.